title of my presentation is Stigma, Double Stigma in African Americans. And I think many of the previous presenters have covered some of the material, the next few slides about what depression is. I think you probably have a good understanding of it both as an emotion that we all feel and a disease caused by abnormal functioning of the brain, and some recent data from the National Comorbidity Study showing the point prevalence and the lifetime prevalence of depression, and the fact that there's a 2-to-1 ratio of females to males. These are the names which depression can be called, and some of the symptoms from the DSM-4, some of the major criteria for major depression. Here are some of the risk factors for depressive symptoms. Perhaps you've heard some of these prior. Being of reproductive age, having difficulties in interpersonal relationships, chronic stress, poor health, recent stressful life events, among others. And the fact that the causes of depression not fully known, but believed to be caused by an imbalance in the brain's chemical messenger system, and the fact that depression runs in families. Patterns of depression, episodes usually time-limited. Most people experience repeated episodes, which makes many of us think of major depression as almost a chronic disease, given how often it recurs. And we take two approaches, treating the disease and the suffering person, the disease with medications and other treatment, and the suffering person with psychotherapy and education and support. But I think many of us know in the general community and certainly in the college environment that depression is very much undertreated. And in some studies showing that 1 out of 3 individuals with major depression didn't seek treatment, and 1 out of 10 receiving adequate treatment. That's really a crisis for us to tackle. But if we look at depressive episodes in terms of the ethnic distribution, we find in this slide that for the most part, that depression, like many other mental illnesses, is an equal opportunity illness. And although we see a significant difference in the lifetime prevalence of depressive episodes among whites as compared to blacks and Hispanics, and this, by the way, is drawn from the Epidemiologic Catchment Area Survey, but for the most part, these differences are a percentage point or less difference from each other, which again leads to the conclusion that depression is an equal opportunity illness. However, where we see disparities is in the differences between the prevalence of depressive symptoms in this case compared to that which gets diagnosed. And as you can see, the difference between prevalence and diagnosed depressive symptoms among African Americans versus Hispanics and Caucasians, there are starker differences between those two in African Americans and Hispanics compared to Caucasians, although we're not doing well across the board in diagnosing the depression that is out there in the community. The Surgeon General's report on mental health, which I believe was referenced earlier, the supplement on race, culture, and ethnicity talks again about mental illness affecting all, but that there are striking differences in mental health care for minorities, and that they are less likely to receive services, they receive poorer quality of care, and they're underrepresented in mental health research. And you might wonder, well, why is that an issue? Well, we base many of our treatments on clinical trials and research, which if minorities are underrepresented in those, then the conclusions we draw from that research will not include the experience of diverse populations. And just to sort of sum all of this up, that these disparities can impose a great disability burden on minority groups. If we look at people of African descent in terms of their mental health care as documented by the Cultural Competence Standards, which were released in 1997 by SAMHSA, their experience is characterized by underuse of mental health outpatient care, with much greater use of alternative sources of care, such as the primary care sector and the faith community, and generally much later entry into treatment, and often with emergency care, which is really not such a good place to receive your mental health care. And with that later entry into treatment, what can come along with that is a poorer prognosis because like in other medical conditions, with mental illnesses, if you don't intervene in a timely fashion, there's a risk that your prognosis will be worse, that your outcomes will not be as good as if you intervened early. And some of you may know that the tendency now is towards even prophylaxis for individuals who are at high risk for mental illnesses like schizophrenia and even depression, that receiving prophylactic treatment before the illness even expresses itself is showing some great promise. Many minority communities are not even anywhere near that point of entering into care. We'll talk more about that later. For those who do enter into outpatient treatment, there tends to be a very high dropout rate after a few treatment sessions, but this is in contrast to the very high rates of inpatient involuntary care. And my colleague, Dr. Alvin Poussant at Harvard, often says that there are only two people in our society who can lock you up, one being a policeman and the other being a psychiatrist. And so it's understandable that this would not ingratiate the African American community or other diverse communities to psychiatric care. People often perceive it as something to be afraid of and to shun and avoid. And then there has been documentation of high rates of misdiagnosis, particularly of schizophrenia in place of mood disorders like depression. M.P.H and others have documented this, and we're really not sure why, but in many cases, some of the stereotypes of African Americans as being paranoid, and then by extension, having paranoid delusions, thinking of that being solely associated with schizophrenia as opposed to ruling out mood disorders first. And we certainly know that delusions and hallucinations can accompany mood disorders too. So hopefully that has changed with greater attention to careful diagnostic practices. What are some of the barriers to help seeking among African Americans? Certainly concerns about what we call double stigma, the stigma of being an African American, certainly with the physical characteristics associated with being African American. People are easily identified as such. And because of the historical place of African Americans in this society as slaves and all that has transpired since then, African Americans are often looked down upon and devalued, and certainly there are many examples of this, really too numerous to count. And then to superimpose on that, the stigma of having a mental illness, that is in many ways a double whammy, which is more than people want to take on. In addition, mistrust of health professionals is a huge issue, and mental health professionals in particular, which really get in the way of people willingly seeking out health and mental health care. And in my community, I'm from Baltimore, Maryland, there until the mid-1960s, psychiatric care was segregated in Maryland, and I know that's the case for many states around the country, perhaps even Michigan as well. And there are all sorts of horror stories about the type of care that African Americans received in that segregated hospital, which just recently has closed. But if you think about it, the mid-60s wasn't that long ago, and in the minds of many African Americans in Baltimore and Maryland, they remember, that people would often be sent off to this hospital and never be heard from again, or come back, not in a good state. So not a very good sense of mental health care. And because of the centrality of religion and spirituality among many African Americans, there are many beliefs that, while protective in some ways and beneficial in many ways, that really get in the way of people seeking help. And one, the belief that prayer alone can heal, keeps many African Americans coming forward for treatment, and there's a great deal of pressure from their families and sometimes from within their given faith communities that if you just get right with God and pray harder, that everything will be all right. And unfortunately, there isn't the same emphasis or encouragement for people to seek professional help simultaneously, while praying and engaging in one's faith. The belief that suffering is somehow part of life for Black people, I think, is a widely held sort of belief. And like prayer, it too is protective and really, I think, helps people face the adverse circumstances that come along with being an African American in this society and culture. But this sense of sort of keeping on and keep on keeping on also gets in the way of people seeking help when they're dealing with adversity, and may contribute to some of the late presentation for health services of varying kinds. And I think much of the focus is on the afterlife, sort of the by and by, and sort of postponing one's gratification and joy until the afterlife, which means that there's sort of an expectation of having to carry a heavy burden while in this life. And so that may underlie some of the reluctance to step out of that and just sort of keep on keeping on. Certainly concerns about addictiveness of medication and the belief that if one goes for help, that's what will happen, one will be medicated, is also a barrier to seeking help. But it's interesting to note that African Americans are more likely to receive treatment for depression from a primary care physician or primary care professional, if at all. And many of us have been working with primary care clinicians to try and support them in taking care of African Americans and other groups who tend to shun especially mental health services because of stigma. And then the other challenge is that African Americans may express symptoms in ways that may be misunderstood. And so even when African Americans do get into the door of a specialty mental health professional, their symptoms may be overlooked or they may end up being misdiagnosed. And certainly ethnocultural influences have an impact on depression treatment outcomes in terms of pathoplasticity, which I'll give examples of in a moment, but that's really a fancy word to describe how a disease or pathos is molded, sort of like plastic, by the individual and the particular cultural context that they're in. And certainly cultural beliefs and preferences, for instance, believing in prayer and so forth, these may also have an impact on outcomes. Certainly provider bias is an issue, even if that is unintentional. And some of you may be aware of the Institute of Medicine report, Unequal Treatment, which showed widespread poor quality of health care among underserved ethnic and racial groups in this country. And one of the things that was pointed to in that report as a reason for the unequal treatment was provider bias. And some of that, again, may be unintentional, but nevertheless can come into play in terms of the treatment decisions that a given provider might make. And then finally, outcomes are influenced by ethnopsychopharmacology, which is a growing area of study looking at the different ways in which members of different ethnic and racial groups respond to and metabolize different medications. And much of the key to this is in the polymorphisms, genetic polymorphisms of the cytochrome P450 enzyme system, which is an enzyme system in the liver that's responsible for metabolizing many medications. In fact, most of the psychotropic medications are processed through this, and we see differences in the speed by which many members of underserved ethnic and racial groups metabolize psychotropic medications, which has an impact on how aggressively we might dose a given medication, and also which medication might we choose in order to sort of predict what the best outcome might be. What if we look at some of the depressive symptoms that we see in adolescents and college students? Certainly loss of interest in activities, enjoying nothing, feeling slowed down or keyed up, having a sense of hopelessness or being isolated, dropping out of activities, and seeing a change in academic performance and even substance abuse. And if we look at sort of the age context and now look at the cultural context, we see many ways in which individuals such as African Americans may present a little bit differently with depression. One complaint might be that, I have bad nerves. And if a given clinician takes this term literally, they might think that it means someone who is nervous or has a lot of anxiety. But in the African American community, this term bad nerves really serves as a shortcut or sort of a polite, socially acceptable code word for mental illness. And it really could describe anything from depression to schizophrenia. And this serves as a less stigmatizing term than the actual diagnosis of depression. And so it's much more appropriate to say, gee, doc, I've got bad nerves, as opposed to saying that I have schizophrenia or that I have depression and so forth. And then we also see that there are alternative presentations of depression in African Americans. There may be the stoic believer, and this relates to the religious aspects that I talked about later, sort of putting everything in the Lord's hands and, denying that there's really any sort of mental health problem. And again, that can delay a person getting the mental health care that they need, because they themselves do not sort of conceptualize what it is they're experiencing as a mental health need. And then the John Henry doer, who just keeps on working and working and working and working until the point of exhaustion. And the fact that many of us as clinicians and practitioners may see a person's ability to keep on working and to be functional as a proxy for wellness. And that's not necessarily so. There are many people who can be quite ill, quite depressed, and somehow keep on functioning, keep on working, perhaps because it is socially and culturally expected of them to do so. So they really are able to somehow transcend the depression in many ways in terms of the sort of stereotype that we have that a person who's depressed is non-functional and isn't able to work. So we have to be careful of that, particularly in African Americans, where this may be, particularly among women, sort of a norm of being sort of multitasking and working to exhaustion, taking care of everyone, and then we might think, oh, gee, that person couldn't be depressed, but we do need to put that in the differential. And then the angry, evil one, the individual who is difficult to get along with, the angry black man, the evil black woman. These have become almost cultural idioms describing people who may be shunned by their family members and friends and social network. And it may be overlooked both by that individual and by the people around them, that person may have a mental health need and very often may have a mood disorder. And this is of great concern, particularly among angry black men, so-called angry black men, who are more likely to be thought of as a bad person as opposed to a person who needs mental health services. And the risk is that such an individual could inadvertently end up in the criminal justice system, particularly if they are large, particularly if in the context of being angry that they become aggressive. So it really is quite a tragedy that such individuals would be overlooked and end up in the criminal justice system where, unfortunately, African American men predominate in this country. Exposure to stressors are very great among African Americans. They are overrepresented among those living in poverty, and we know that poverty is a risk factor for mental illness and depression. Certainly racism, regardless of someone's socioeconomic status, is something that African Americans across the board experience in a variety of different sectors and arenas, in housing and education, in so many employment and so forth, and certainly racism, experiencing racism can trigger depressive symptoms. Violence, which unfortunately occurs at a very high frequency in poor minority communities. And if we think about the losses associated with that, not only loss of life, but loss of functioning, as well as the people who witness the violence and the sort of trauma that they experience and the depressive symptoms that can be associated with that. And then if you add all of this together with the greater morbidity and mortality that we see among African Americans from the leading causes of death, heart disease, stroke, diabetes, HIV/AIDS, and on and on and on, you see a great deal of loss and grief which can easily trigger depressive symptoms. I'm not going to focus much on this slide about suicide. My colleague, Dr. Moloch, has covered this very well, but it showed some of the increases in suicide rate in the last couple of decades, which has begun to plateau for black males. And for many of you, you know that there's quite a stigma associated with suicide in the African American community, that people are becoming more aware that this is indeed a reality. I put all of this together in what I call a vicious cycle, which probably exists in most communities, but is particularly virulent among African Americans. If we think about depression being in the center and the risk of depression being compounded by substance abuse through self-medication, and in African American communities in poverty, there is a great proliferation of liquor stores and great availability of illicit substances, cocaine, heroin, etc., which really increase risk for people to reach for these substances for self-medication purposes, which of course brings on a number of different problems. We can really go in either direction of this cycle. Certainly increases the risk of poor physical health, and certainly use of substances increases risk of sexually transmitted infections, HIV, AIDS, hepatitis, etc. And we can also go in the other direction, that substance abuse superimposed on mental illness like depression can increase risk of being a perpetrator of violence or a victim of violence, and certainly incarceration, which we know is probably one of the worst places to try to receive mental health care. And many of you know that mental illness in general has been very much criminalized, and we now find that the largest number of people with psychiatric illness are in the correctional system. And I think I told you earlier the predominance of African American males in that system. Of course, all of this can have an impact on one's socioeconomic status and prosperity and well-being. So we really want to be able to interrupt this vicious cycle. But we still have a problem. We talked about the barriers to people getting in the door of a mental health provider, or even for that matter, a primary care provider to get some sort of care. But even when people get in the door, they tend to receive lesser quality of care than whites. And in this study from Wang and colleagues, it was found that African Americans are 10 times less likely to receive guideline-consistent care than whites. And guideline-consistent care in this study was defined as either receiving a prescription medication for depression or anxiety from a general medical doctor or psychiatrist, plus at least 4 visits to the same type of provider, or receiving at least 8 visits to either a psychiatrist or a mental health specialist in the absence of medication. When we treat depression in African Americans, it's really important to emphasize the non-addictive nature of antidepressant medications, given that that's a concern and has been cited as a barrier to seeking care, and that counseling may be the preferred mode of treatment. And no matter how hard we might advocate or try to convince the patient that they need to be on medication, they may just not be interested in that, and counseling may be the way to go, which is fine because we know that counseling and psychotherapy can be an effective treatment for depression. But of course, as with other groups, education and support is really crucial, given that an individual's family member may have strong proscriptions against taking a medication or receiving mental health care for that matter. They may not believe on it. And so understand that your patients may be under, or patients or clients rather, may be under great pressure not to adhere to a given treatment plan. So what are some of the interventions for narrowing this gap between those who need depression care and those who actually get it? I think it's really key to educate gatekeepers, whether they be members of a student body, perhaps empowering peer counselors or resident assistants, RAs, or whatever you might call it in your institution, making sure that there are supports or at least education of personnel in the infirmary, which is maybe the first place that many individuals will come who have mental health needs. They may feel uncomfortable walking into the door of something labeled counseling center or something that specifically refers to mental health services. Certainly professors need to be aware, and the faith community also, because these are all individuals or places to which people may turn instead of going straight to a mental health provider. Depression screening is also a very good way to educate people about what depression is. I mean, there is a learning process involved in actually filling out a depression screening form, but it is a way of uncovering depression that might not otherwise be noticed. Having a well-staffed counseling center with the availability of on-site psychiatric consultation is really an ideal situation. I was very fortunate over the last several years to have worked in partnership with the Morgan State University Counseling Center, which is located in Baltimore. And that was a very fruitful relationship. And actually, Dr. Myra Waters is here in the audience. She's one of the psychologists on staff in the Morgan State University Counseling Center, and really doing quite excellent work, and recognize that if their students were going to receive mental health services, that it needed to occur on campus in the counseling center so that you did not have to worry about sending John's student or Susie's student across town, a crooked mile to XYZ Community Mental Health Center, which upon arriving at that place may not be a particularly welcoming setting, and the sort of interaction with the provider may not be optimal either. And what you end up with is a student who hasn't received any treatment at all. And so by making services available on site, that goes a long way to keeping people from falling through the cracks. And we've done a lot of good work there. There have been even students, well, certainly students with depression, students with schizophrenia, who we've been able to see through their 4 college years and to do quite well with working in partnership with the psychiatrist and psychologists on staff there. Advocacy organizations. We're fortunate to have in the state of Maryland the Black Mental Health Alliance for Consultation and Education, and it has frequent conferences, is a clearinghouse for information on mental health in African Americans, including a Kellogg-sponsored information packet called The Souls of Black Men that is a very touching and moving account of how Black men feel about having mental health needs and ways of reaching them better. And then the National Mental Health Association and the local Mental Health Association of Maryland has made some very productive inroads into linking with the faith community with a project called the Praise Project, which is now based at the Institute for Mental Health Ministry, which is doing a lot to integrate mental health services and spiritual principles as a way of reducing barriers to care among African Americans and others. It's certainly not limited to African Americans, but really any individual who finds it appealing to have spiritual principles integrated with their mental health care. And then finally, other interventions are the use of culturally tailored videotapes, Black and Blue, which I'll at least tell you about and hopefully show you in a moment, and Mood Indigo. Mood Indigo, The Unexpected Faces of Depression, is a videotape developed by Dr. Melva Green, who's a Hopkins-trained psychiatrist and an American Psychiatric Association research fellow. She can be reached at melvagreen@yahoo.com. I'm spelling this out because this is not in your handout. This is a slide I added because Dr. Green had hoped to be with us here at the conference, but had a conflict and wasn't able to attend. And I promised to share with this audience her video, at least to tell you about it. This video features African American drama students from Morgan State University who depict depression in the form of promiscuity, substance abuse, and anger and violence. And it's a very effective video which she plans to evaluate using qualitative approaches, using focus groups. And she has engaged a number of historically Black colleges and universities to evaluate the video in those sites. And so you may be interested in connecting with her to hear more about what she's doing. So this is very exciting, and not only are we culturally tailoring to a certain ethnic group, but also to a certain age group within that ethnic group, which I think is important. I heard earlier when one of the speakers was talking about the Real Men, Real Depression campaign, that having someone who had an earring helped people, graduate students, identify with that person. And so it's important to make sure that there is cultural tailoring to increase the identification of your target audience with the information that you're presenting. Black and Blue is a videotape that I developed to help reduce some of the stigma about depression that I saw in the African American community. I worked for many years as director of community psychiatry at Johns Hopkins, which is smack dab in the middle of a predominantly African American community. And I did a lot of home visits and working throughout the community, from the Ivory Tower into the Ebony community, and saw a great deal of depression that was being overlooked and in many cases underdiagnosed and undertreated. And so I felt that one way of leveling the playing field with information was to do a video as opposed to doing another brochure, which people who can read don't read, and people who can't read or have low literacy levels are not able to access that information. And so using videotape as a medium of communicating health information is very useful. And culturally tailored videotape in particular, you're able to add some additional elements to, again, increase identification with the subjects. There are both 9-minute and 16-minute versions of the video. It features African-American adults who've had depression themselves, who speak to it from their own personal experience. It's very genuine, very moving. There is a member of the clergy who speaks to the importance of getting help while still, being a religious person, that those two can coexist. And also presents psychiatrists and other health and mental health professionals. It really seeks to stress depression as a medical illness and to emphasize the importance of early recognition and treatment. And also discusses some of the standard treatment approaches and increases awareness of some of the negative consequences of untreated depression while providing information on how and where to get help. I was fortunate to be able to evaluate the Black and Blue video a few years ago. And the way I went about this was to recruit individuals from health fairs and other sites in the community where depression screenings were held. And in fact, one of them was a National Depression Screening Day that we were able to recruit individuals to participate in this. And we gave each individual in the focus group a pre-test on knowledge and attitudes about depression and a post-test. And in between the pre and post-test, they saw the video. So we really wanted to see if there was any change in the percentage of individuals getting the quote-unquote right answer to the questionnaire, if we would see any changes in that percentage after watching the video. I'll tell you a little bit about the results in a moment, but we also conducted a standard focus group getting feedback from the participants about how the videotape struck them, and we basically organized their responses and categorized them. And what I'm pulling out from here is among the college students who participated in these focus groups, I wanted to underscore some of the things that they said, which really helps us understand the level of stigma that's out there, even in African-American college students, and what it is that we're up against, so that we can be very realistic about how we go about trying to engage members of this group. Here's one comment. I think as Black people, we tend to use defense mechanisms. We hide our feelings rather than verbalize them. Another point, as African-American children, we're taught to be strong. Don't let them see you cry. You don't want to say, I need help. And then another point, most Black people consider depression to be a white person's problem. And so again, what we're up against is to sort of challenge some of these very embedded notions in the African American community. And certainly what we see in the larger community, we certainly see sort of in the microcosm of a given college. And in this case, these were individuals from a historically Black college and university. Here's some other points. I wouldn't talk about depression with other people because I don't want that stigma. And my mother said, let go and let God, and you better not go to any doctor. So again, that some of the barriers that may be presented by the family member given their strong belief system. So this is what people are up against when we approach them for care. And then another point, a comment from someone's father. When I told my father I was going to National Depression Screening Day, he said, you're too young. You don't have any real problems. So again, all of some of these are myths and widely held beliefs that serve as significant barriers, or at least add to the stigma associated with depression. After analyzing the results of the evaluation of Black and Blue, I found that there were significant changes in significant changes in the correct responses to a number of the questions on the questionnaire. Those related to stigma, those that related to spirituality and depression. And the question on the questionnaire was, prayer alone can heal depression. And there was a jump from 47% of people who agreed with that prior to seeing the video, to 97% who agreed after seeing the video. And treatment with antidepressants and viewing depression as a medical illness. The results of this evaluation are presented in an article in the Journal of the National Medical Association, which was published in November of 2002 for those who are interested in learning more about the details. Black and Blue is available from the filmmaker who worked with me on this, Blue Rock Productions. Greg Landry is the actual film maker's name. It is available on VHS, CD-ROM, and DVD. And if you're interested in getting copies of the video, you can call Blue Rock Productions at the number shown, and that should be in your handouts as well. I'm not sure how my technician friends are doing with it. Hopefully we can show the DVD. I don't know how much time we have. What time do we need to end here? Sorry about that. 4:15? Okay. Well, I think we have time. The video itself is 16 minutes long. Should I just close out here? Okay. I'm sorry? Oh, thank you. Did I see the shorter or the long version? You saw the long version, the 16-minute. Okay, just pull it out. Oh, sorry about that.
Give us about 2 minutes.
It's in pretty tight.
It occurs to me that perhaps a conversation around how we think, since people, African Americans, have been held in captivity in this country longer than we've been free, how much, and perhaps even up into the 60s, lived under a sort of terror, what effect, or ongoing or lasting effect, might that have had on us? And are there ways of perhaps for us to begin to look at that and process that experience and maybe lose some of that baggage, or I'm not sure.
That's a challenging one. Certainly, racism exists in many forms, and has had long-lasting effects on people of African descent here. One impact it has had is to trigger in some people a certain self-hatred, because the way that we are seen as African Americans, you can sort of join in with that and do things that are self-destructive and also that are destructive to other African Americans like yourself. And I mean, this is a huge issue. One example is the black-on-black violence that we have seen and can continue to see very high rates. What can we do to fix that? I think that on an individual level, certainly for those who come forward for counseling and therapy, that we can begin to sort of unpack some of that baggage and help people process it, to help them see themselves in the context of family, of community, of society, and help them understand what the impact of racism has been through knowing what it is, to getting sort of an intellectual and cognitive sense of it, to be able to strip it, of some of its power. Some of the work of psychologists like Dr. Janet Helms, who I think was at University of Maryland, she talks about, some of the different stages of identity formation, and her concepts, I think, are particularly helpful to people forming a positive racial identity. As it relates to undoing racism, that's not your question.
The question has to do with how we see ourselves. I can remember at being 18, which was a long time ago, and thinking that, how can I be proud of a heritage of subjugation? Although I did visit the African American Museum in Detroit lately, their new exhibit tells our story in a wonderful way, and tells it as a heroic story.
Mm-hmm. Well, I think that is an important thing to stress, is the triumph over adversity. I mean, we are a people who have survived despite, continuing assaults and, a very difficult beginning, and that somehow, we still survive, we still thrive in many ways, although, in many ways we're not thriving as a community. But I think, helping people to look back at what our forebears had undergone and overcome is sort of a starting point for realizing, what strengths we do have and what we have to work with. But this is no small matter. It's a very serious matter, and I think people in the audience listening to this, they may think this is perhaps an unusual and deep sort of thing, but many of the patients that I have worked with have come with very similar sorts of questions to work on in the context of therapy. So I think it's a critical issue. Yes.
Okay, I have two quick questions. One question is, you were talking about how certain SSRIs are metabolized. Do you know of anyone, or can you drop a name of someone who's done research specifically in that area? And also with depression and anxiety and other mental illnesses being genetic, what's the prevalence of that? And also, can it also be gendered?
What was that last point? Can it also
be gendered with the genetic?
Okay. Yeah. Right.
Can be certain carriers, I guess.
Okay. The first question was about people who are doing work on ethnopsychopharmacology. Dr. William Lawson, who is a psychiatrist and chair of the Howard University Department of Psychiatry in Washington, D.C., he's one individual who's been working on this. And another is Dr. Diane Bradford, who is at Morehouse School of Medicine, and she's done a lot of important work in this area. Dr. David Henderson at Harvard University has also done work in ethnopsychopharmacology. Your next question, could you remind me again? Sorry.
It was basically just asking about how prevalent is genetic, what's the role that genetics plays in depression, anxiety, and other mental disorders, and can it be gendered as far as certain sexes carrying certain diseases?
Well, we find that depression does indeed run in families, that people are genetically predisposed to having it. So that means that if, let's say, your grandmother had depression, your risk of having depression is higher than a person who doesn't have a relative with depression. But it's no guarantee that because your grandmother had depression that you would get it. And we find that the further away in terms of your relatedness to a given relative, the lower your risk of depression. So, a first-degree relative would have a higher risk of depression than someone like a cousin, for instance. But it's, again, the predisposition to depression. And so there are some people who may be genetically predisposed but never actually experience it. And so there is sort of a combination of the nature, or sort of the biological or genetic underpinnings, and then the nurture or the socio-environmental context. So, each of these factors can come into play. Certainly, depression, the prevalence of it is twice as high in women than in men. I don't know that we really understand exactly why that is. There are a number of different hypotheses, such as, some of the hormonal hypotheses that the differences in hormones among women may predispose them, the difference in their social roles and the expectations, and may also play a role. So a number of different factors come into play in those gender differences. And I think at least in, I'm not as sure about this, the risk of, the passing on of mood disorders, in particular bipolar disorder, through the mother, in some males who have it. So those are some of the gender issues. Looks like we are giving up on the video. I'm so sorry. When Dr. Greedon invited me to speak here, I think that was one of the things that he wanted me to show, and I did not list that on my request for equipment, and just remembered that. So we did give it as good a try as we could, so thank you for your patience. Yes, it's available through Blue Rock Productions, which is a film company that made the video with me in Baltimore. And the phone number to Blue Rock Productions is 410-358-7000. That's 410-358-7000. The video is $35, whether you get it in the VHS format, the DVD or CD-ROM format. Yes.
Hi. One aspect that I think I would have liked to hear in this presentation was how to sort of manage unrealistic expectations as far as treatment and therapy versus realistic. Because I know when I lost my dad to suicide a couple years ago, a lot of his resistance to seeking care was, him sitting in a room talking to people who might have a similar situation to him or might understand where he's coming from wasn't as valuable to him as getting help for some of the financial situations that he was in, or a lot of the just trying to get help in other aspects. So, his expectation of therapy was, it's not going to do any good because this isn't, as critical to me being able to live through my experience with whatever, he was burdened with, rather than, not. And so I know that I've been spending time trying to figure out, just if I'm ever asked, for people who know my experience with his suicide and, want some kind of feedback, what kind of help can I give as a friend, as a family member, as a suicide survivor, to help people feel better about whatever expectations they have about therapy, whether they feel like they're going to get their head examined, whether they feel like, how long is this going to take, because some people want to get better in 3 months, and if I go and make this expense and carve out this time and this money to do this therapy, they want some type of guarantee that something better is going to come out of it. And so how do you deal with that? How do you help people to understand what they can expect from therapy?
Well, I think, again, using tools like the video do spell some of that out. I think it's an important question because even with the medications we use, they do not instantaneously relieve depression. It takes, some weeks. So that's one of the first things, is to, ask the person, really bear with us while we, treat the depression. It may take some time, but while you're treating, you're also providing counseling, providing hope. And, you really cannot ignore the environmental context in which a person is seeking help for depression, and that what's going on in their environment may actually feed the depression and may make it worse. And so if there are financial concerns, if there are marital issues, if there are other things going on in that person's life, it's not like you can just sort of cut out the depression and put it over here and only work on that. It's in the context of someone's life, so you really need to treat the whole person. And a good therapist working with an individual will pay attention to that and will identify supports or resources to help persons with some of the stressors in their life which are contributing to the situation. And so it may not be, just enough for them to be in a support group, although helpful. But you may need to look at a number of different types of supports and resources to really engage that person's sort of trust and let them know that you really care and that you really want to work with them, and you're not just treating their depression, you're treating them with whatever is going on with them. So you really need to take, I think, a very broad view, of that individual and their life context, and not just limit it. And so, but being helping that person to have realistic expectations about even the side effects that the person may experience. I find that if I didn't let people know what they might expect, that if they got a certain side effect, they would fly off the handle and I would lose them forever. And so I tend to be very gentle in prescribing medication, starting low, going slow, letting them know why I'm doing that, letting them know that it may take several weeks for the medicine to work, and to let them know that if it doesn't, we can try something else. That this is actually there are a number of different agents that we can use now. So and then also supplementing that with psychotherapy, some of which may need to be problem solving and supportive in nature. So I think that's a way of sort of taking care of all of the concerns that the individual may have that may contribute to the depression or relief thereof.
Time for one more.
Thank you.
Please join me in a formal way. I'll apologize for the video. That's mostly in the context of time and busy schedule, I'm going to actually just launch in. I'm not sure that one of the groups upstairs has even ended, but this is an amazingly long day when you sit and go through all of this. And it's my job to try and summarize, but more than anything else, when I did this last year and the year before, I used it as an opportunity to really just get input from what I call the real hardcore, so you get a vote. But I'm not even going to try and summarize. What I'd really like to do instead is to convey at least my own judgments all the time are, did I learn, did I have some experience? And in this particular circumstance, I had an overwhelming and a very positive 2 days. And in the context of that, I'd like to do 6 things. One is to thank. And first, it's the people who did the planning. I'm only one of many. And in fact, as you've heard, others did most of the work and the linkages. Second, it's the participants, the speakers. Third, it's, I guess, the the people who really also deserve some acknowledgement. Many of you don't know this, but I'd like to thank our campus leaders, simply because the choice was made 3 years ago when we started this that we would not solicit support from others, such as, for example, pharmaceutical companies. And money always becomes an issue. So your tuition would have been about, double and more had you not had support from the deans of about 7 or 8 schools and the Department of Athletics at the University of Michigan, all of whom contributed to help make this possible. And I'm very proud of the university in that sense. And then you already heard the thanks to our students. The second one is to convey some sense of pride. I don't think always appreciate whether it's in our role, and I heard the last comment, in our role as survivors, as parents, as siblings, as clinicians, as friends, the student panel, all the portrayals. We do hard work. This field is not easy, and I think what this topic conveyed is how hard it can actually be because of this last variable, namely stigma, the one we've been focusing upon. And I'm very proud to sort of have all of this group as colleagues and as participants in the overall initiative that we're doing. The third item is to sort of do something that is kind of a theme that's been out there for the entire time, and that's to do a call to action. And this is a theme that we've been talking about. I think Howard conveyed it best. Some dispute about what Confucius really said, but because none of us were here when he said it, I'll go with his version. I do and I understand. And I think that doing is now what's necessary. And all of us probably need to be active in whatever way works for you. Some do it differently than others. Paul this morning was active in his way, and he kept using the word angry. Some may do that effectively. I think he did. Others won't. Be specific. Be collegial and collaborative and multidisciplinary. I think we all need to learn from each other and not reinvent the wheel all the time. That just minimizes the resources that we do have. And we'll try to work to help all of you by basically collating some of these things by working with the contributors, those who made the actual presentations, and by essentially distributing the pieces that I referred to as the action steps. I really think those are the components that really are necessary. This is one of those where if we don't walk the talk, then we're not making enough difference. The fourth item is more just a clarification. I want to use this opportunity during the break. Actually, after this last thing, I want to either, number one, apologize, or number two, clarify. I got up at the end of the panel presentation, the last one that was done with the group of 6, and made a comment. And I think I may have either done it not in a very good way or not clarified what I really meant, because someone came up to me and said they thought it was insensitive. And to clarify what I really meant, and then if there still is something, I wish to apologize. What it was that I was trying to say is I love chasing what are big goals. If we don't really seek something that is an ideal, we're missing the boat. And in many ways, it's, for example, what led us to formulate a comprehensive depression center to really bring something to attention here, and it's working so far. So big goals are a good ideal. In the meantime, no matter what we're doing, whether it's geriatric psychiatrists, child psychiatrists, or the issues that we've been dealing with, how do we manage to come up with an adequate number of providers who have cultural competency and, frankly, evoke a comfort level among those that need help? We got a huge gap between where we are and what that ideal is. And what I was trying to do is to get the panel to help me, as a chair, for example, and as someone who has a bit of a national voice. We've got to address this collectively. How do we fill that void? How do we get the pipeline? And how do we get the population more comfortable with trying to address what is there right now? Because it's going to take us a while. That's the frustrating part about this, to go from where we are now to where we really should be. And I don't want to wait that long. And so if I misstated something or really was insensitive, this is not a problem of, for example, the minority community. It's a problem for all of us. It's a problem for me as a chair. It's a problem for those who pay the bills. It's a problem for insurance providers. And I think what we've got to do is to address all of the data that were presented by the panelists and others. So I'd be glad to discuss that further with people, but in the context of what was an exciting 2 days for me, what I certainly don't want to do is to minimize the impact by contributing. The next one is actually to suggest that we have an opportunity. And this is, it'll sound like it's a real paradox, the way that I'll convey it. The opportunity is actually something. I was at a conference recently, and I'll give you the source, and it'll be funny. So it was not a conference, it was an advisory group, and one of the speakers was Hank McKinnell, who happens to be the CEO and the chair for Pfizer Pharmaceutical Company, the world's largest pharmaceutical firm. They have their research headquarters in Ann Arbor, they're next door. His office is elsewhere, but this was a meeting in which he got up and he talked about their directions. And he said, because of what he does, lots of people come up to him and they ask him, assuming, Ajay, you're involved in this, you should know something. What do you think of the American healthcare system? And he said it reminds him all the time of a question that was asked of someone far more famous than what he will ever be, his version. And that person was named Gandhi. And he said Gandhi was asked a question of, what do you think of Western civilization? And he said, I think it would be a good idea. And the American healthcare system would be a good idea. We don't have one right now. That's just, I think, trying to be as objective as I can be. It's a sick system and a sick care system, and it's not working very well. And I think anybody who looks at it right now, including all of the political officials, say that. Everybody says it. Corporate worlds. We've been hearing today about one of the variables that's unique, a little bit more unique to us. Not totally, but it's probably a bit more prominent, and it's one that we have to take on with our particular thing. So how's that all an opportunity? It's my read, and I hope I'm right, that our society is going to address and I think challenge everybody very soon about revamping this system. It can't go on this way very much longer. Our costs are skyrocketing, and yet we're not making any progress. We're actually losing ground in infant mortality, for example, to some of the other networks. We have some people who get great care. We have others who get absolutely horrendous care. We have 45 million uninsured and growing, on and on. We know all of the issues. What I would like to make sure all of us help promote is the fact that when this revamping, if you will, this good idea of creating an American healthcare system goes a bit into action, let's make sure that mental health and our pieces are part of this. And that's going to mean all of that action that we were talking about earlier has to take place. Your voices really then become crucial. Now with that, those are just some, I didn't want to reflect anymore on the content because I don't think I could do justice to summarizing it. This has been year 3. All of you heard my commentary about how difficult it will be to do this in the framework of each year. We have to pick a theme if we're going to continue. Sarah and Lynn and others have been in many ways the driving forces. So my first question that I asked last year and the year before is, should we do this again? And the rest of this time is yours, and then I have some final housekeeping items about taxis and whatever else. But questions, comments? Should we do it again? You have to put some words to that. This is an old thing. As somebody now who at least believes they know something about research, one of the things that I realize that we have here now is we have what's called sample bias. you're the only ones here right now. That says something. I mean, this has been, with 600-700 people who have been registered. We've had a lot of people. I think the others have shared this viewpoint. But what should we do? And, your perspectives on themes, topics, etc.
I'm Alan Fisherman. I'm a private physician from Houston. Found out of this by email from somebody, and yes, this is a good thing. This thing should be repeated. You don't necessarily have to have something new next year. You could repeat what you did 2 years ago, because how many people do you have coming to this, and how many people need to be could come to this? So, repeating it every 3 years is not a horrible thing.
Well, it's actually been an annual thing now, and yet at the same time, yeah. Oh, I see. I got it. Yep.
This is the third year of doing something different. So you don't have to have something new next year. You can do what you did 2 years ago.
Well, themes that have been already told to me in the hallway back outside by coffee, etc., have been things like, let's look at comorbidity issues. Let's look at the coexistence of problems. Somebody said, let's do this again, but really focusing more on what do you do clinically with diversity issues. Somebody else said, what we really frankly ought to be doing is having an entire session devoted to the cost aspects, because that's the only thing that the administrators who support these things will pay attention to. I've gotten 3 suggestions. All of them tend to have a specific theme that could be done, I guess. I mean, we spent a lot of time as a planning committee trying to deliberate this year, and this emerged as the selected theme, but it always helps to get input. Go ahead.
Hi, my name is Rachel Dietrich. I'm a freshman at Washington University in St. Louis, and I'm here on behalf of our mental health outreach program. So it's a great experience. It's been wonderful. I've learned so much. My favorite part was the last panel on diversity. I think that is such an important topic, because as an American, how do I, as a student, reach out to international students or minority students? I'm second generation myself, but I'm still an American. So I just think that diversity and depression would be just a wonderful topic.
Okay, any others? By the way, it would have been very easy, just as you're getting up to make this comment, think of 2 sessions today that I was at least aware of, namely where we had the panel, Mort Silverman, Richard Gaddison, that whole session that was there. We could have had an entire day just on those topics. Maybe 2. We could have had an entire day just on the last panel that you're referring to, wherever you went. I can't see with the lights. It would be very easy to go further in depth with some of these issues, but those are good suggestions. Go ahead.
So much as a parent, and I think the students learn quite a bit, and it's good to mingle and see everyone's point of view. I think that's terrific. And a theme that I would suggest are maybe steps towards success, trying to incorporate maybe what we heard at the lunch, that we need to project a positive point of view and promote healing.
I like it too. Others? Go ahead.
My name is Tamina. I'm from UC Berkeley. I wanted to echo the sentiment that economics and funding for campus healthcare could be an expanded topic, because I think a lot of the public universities are coming up with creative ways to fund healthcare. It would be good to hear what everyone's doing. The other thing I wanted to say is I realize we have a lot of work to do on implementing improvements on each individual campus, but moving toward building activism at the federal level, I think would be great, and maybe 5 years from now we could do something related to that.
And you have a special interest in that, and some data. Yeah, go ahead. Go ahead over here. Yeah.
Thank you and congratulations. I'm Stephen Stovey, a psychiatric nurse practitioner here at the University of Michigan. And in terms of just a practical suggestion on how to get input for the next conference, I would recommend that participants here have an opportunity to return home with some of the exciting ideas that have been generated here, set with those and discuss those with some of your colleagues back in your own respective settings, find out what it is that's wanted and needed across the country, and then perhaps just an email solicitation of the participants' lists than to ask for that input when people have a little time to digest this and think more about how it applies to them and their practices and settings at home.
Sarah, Lynn, or any of the others, did we get emails from everybody as we had them register? Did you?
I believe I saw what looked like a very impressive list with reminders about last-minute logistics. So I suspect that a good number of people are on that address list.
Okay, good. Because in some way it'll probably also be our conduit for communicating information back about action points. But that's a good suggestion, Steve. Thank you.
I think it might be beneficial to have a section or discussion at least on political activism, to the extent of how can we at our different roles come together and lobby, quite honestly, for things like more funding through state governments and local governments and national governments to aid us in these causes.
Another good suggestion, Molly, and I just have to ask you to do me a personal favor. When you go home, I mean, this conference started when a number of us, including Earl Lewis, sat around and decided we should do this. And Earl is now the provost at Emory, and if you haven't met him, perhaps you have, but if you haven't, please do. He's sorely missed here. So you should be thankful you have him.
Dr. Gurdon, my name is Larry Lewis. I'm with SPAN of Michigan, Suicide Prevention Action Network, and there's already a political